Well,
Buenas tardes.
good afternoon.
Nuevamente
Again,
agradezco
I
al
thank
comité
the organizing
organizador
committee
por la
for the
posibilidad de
possibility of
participar con ustedes
participating
en
with
este
you during this
importante
important
congreso.
Congress.
En esta
This time
oportunidad vamos a
around, we will
hablar
talk
del
about
SARS.
SARS. What is
¿Qué es el
SARS?
SARS? El
SARS
SARS
is
es
the
la electrostimulación de las
electrostimulation
raíces
of
sacras
anterior
anteriores
sacral
para
roots
el manejo
for
de los pacientes
handling
lesionados
spinal cord
medulares.
injury patients.
No hay
I have no
conflictos de interés en
conflicts of
esta
interest
charla
to mention in this
y
talk,
esto
and
en
well, this
realidad
has been
se ha
developed
desarrollado
because of
a
the
consecuencia
pioneer
del
work
trabajo
done by
pionero
Dr.
del
Giles
profesor
Brindley
Gilles Brindley
in the United
en
Kingdom.
Inglaterra. De
Early in the
principios de los
70s,
años 70,
he
él
became interested in
pensaba en
developing
desarrollar la
electromedicine and
electromedicina, la
electrostimulation,
electroestimulación,
and
y en
his
su
pioneer
trabajo
work
pionero
with
en
primates
simios, posteriormente
has,
ha
as a consequence,
derivado
brought us
este
to this
concepto.
concept. And the
Los
pioneers have
pioneros han
obviously
sido,
been Brindley, like I
obviamente,
said,
Brindley, como yo les he
but
dicho,
also in the United States,
pero también
Dr.
en Estados Unidos,
Tanago
el doctor
and Richard
Tanago, ¿no es
Smith at
cierto?,
San
y Richard Schmidt
Francisco
en San
UCSF.
Francisco, la UCSF.
Also in the 70s,
También en
they
los años
started
70
to do
iniciaron
pioneer work
estudios
in the use of
pioneros en
electromedicine.
el
I
uso
was
de la
lucky enough to get trained in San
electromedicina.
Francisco
Yo
with
tuve la
Dr.
suerte de formarme en
Tanago
San
and Dr.
Francisco
Smith,
con el doctor
and I
Tanago y
was
el
able to
doctor
see
Schmidt,
these
y me tocó
techniques
ver
in
este
their
tipo de
early
técnicas en sus
beginnings many years
comienzos
ago.
hace ya hartos años
Eventually,
atrás.
SARS
Posteriormente el SARS encontró aplicación
found
clínica
clinical
y
applications,
hay
and
varios
several centers
centros que lo
developed it, and as you
desarrollaron,
see, mostly in Europe.
fundamentalmente, como ustedes ven, aquí en Europa.
Interestingly enough,
Ya,
it
interesantemente,
didn't
no hubo
take or
mayor
wasn't applied in the
aplicación de
United
esta
States,
tecnología,
not
de
as
este
much.
concepto en Estados
In Latin
Unidos.
America,
Aquí en
the pioneer
Latinoamérica,
center for this
el
has
centro
been
pionero ha
the center
sido
in
el
Medellin in
de
Colombia
Medellín,
with
en Colombia,
Dr. Juan
el
Carlos
doctor
Castaño,
Juan Carlos Castaño,
who is most definitely
sin
the
duda
Latin
es el
American
líder en
leader and one of
Latinoamérica
the world
y uno de los
leaders
líderes mundiales en el uso
in the
de
use of
este
this
concepto.
concept.
Pero ¿qué es lo
What
que es el
is
SARS?
SARS?
El SARS
SARS
viene por,
comes from
como
the
ya les
name
decía,
Sacral
por
Anterior
Sacral
Root
Anterior Root
Stimulator.
Stimulator. Es
This
un
is a
dispositivo
medical
médico
device that
que
has
se ha
been
desarrollado
developed
para efectuar
in order to
una
provide a
estimulación selectiva de las
selective
raíces sacras de manera
stimulation
de
of
controlar
sacral
la
nerves in order
función
to
de
control the
algunas
function
vísceras y
of
algunos órganos
some
pélvicos,
intestinal areas
especialmente, o sea,
and pelvic
fundamentalmente
organs,
en pacientes con
especially
lesión de la
for
médula espinal, o
spinal
sea,
cord injury patients,
parapléjicos y
paraplegic and
tetrapléjicos.
tetraplegic. Its
Entonces,
primary
su
objective is
objetivo
to
primario
restore the
es
functioning of the bladder.
restaurar la función de la
Also,
vejiga.
as an alternative, as a
Además,
secondary
como
alternative,
alternativas
it can
secundarias,
help with
puede ayudar para la evacuación
bowel
intestinal
movements,
y
and they
también
can also trigger
puede
erections. At
gatillar
this time,
erecciones.
unfortunately,
En
it
este
is
momento,
only
desgraciadamente, es
manufactured
fabricado
by one
solamente en
company,
una empresa,
British company called
la
Finetech.
empresa
They are
británica
the only ones
Fintech,
who
es la única que lo produce y
make
que lo
it and
distribuye en el
distribute it in the
mundo.
world. How does
¿Y
it
cómo
work?
funciona?
This
Este
system
sistema
has
tiene
external
partes
parts
externas
and
e
internal parts. Let us take a
internas.
look at the internal parts. The
Primero
internal
veamos las
parts are
partes
put together by
internas. Las partes
electrodes.
internas están constituidas por los
These ones you see right
electrodos,
here, three
que son
electrodes
estos, son tres
that are
electrodos
placed
que
as
se
I will
colocan, como
show
yo les voy a
shortly,
mostrar,
and a receptor
y
block.
un bloque
This
receptor.
receptor block
Este bloque
is
receptor
connected to
va
these
conectado a
electrodes,
estos
and it is
electrodos y
implanted
se implanta
internally under the
internamente
skin
bajo la piel,
inside
dentro
of the
del
patient's
paciente, ¿no
skin.
es cierto?
And
Y
there are external
hay
components.
componentes
One of them is a
externos.
controller,
Uno es el
this one you see
controlador,
here,
que es este,
a sort
que es
of
una especie
external
de estimulador
stimulator,
externo,
looks
así
like a
como
cell
un
phone,
teléfono celular,
a
un
connecting
cable
cable,
conector y
and
esta que es
this
una antena transmisora.
transmitting antenna.
Entonces,
What does
este
this
esquema
show?
lo
The
muestra. Los
electrodes are
electrodos están
implanted
implantados
internally in
internamente
the
en las
roots,
raíces, en la distribución
distributed
conveniente,
conveniently,
y
and
los
the cables
cables
go
van por
under the
debajo de la
skin
piel
all the way
hasta
out to
este
this
bloque
receptor
receptor,
block you
que
see
es
right
este que
here
está aquí,
placed
que se
under
coloca
the
debajo de la
skin,
piel, generalmente por
generally
sobre la
by
parrilla
the rib
costal en el
cage
flanco
on the
derecho,
right flank,
y entonces
and
la
the
antena
transmitting
transmisora se
antenna is
coloca
placed
por sobre el
over
bloque
the
receptor
receptor
a través de
block
la piel
through the
y
skin, and
mediante
through radio
radiofrecuencia
frequencies. It will
produce
produce
una
a
estimulación de las
stimulation of
bobinas
the
que
coils
están
in
en
the
el bloque
receptor
receptor.
block.
Entonces,
So that radio
esa
frequency,
radiofrecuencia, al
upon
estimular
stimulating these
estas
coils,
bobinas, induce
induces
corriente
electrical
eléctrica
current
que
that is
se
then
transmite a
conveyed
los
to the
electrodos y
electrodes
que
and
estimula las
stimulate
raíces
the
sacras. Por lo tanto,
sacral
este sistema
roots,
no
so it
tiene
does not
baterías
have
internas,
internal
sino que
batteries.
la corriente
The
es
current is
inducida
induced
de manera
transcutaneously
transcutánea por
through
los
the
estímulos que
stimuli
vienen
that
de la
come
antena
from the
transmisora
transmitting
mediante
antenna through
radiofrecuencia.
radio frequencies.
Y esto tiene
This has
tres
three electrodes
electrodos y
and
tres
three
bobinas,
coils or
tres polos
poles
que
that are
son
useful and
útiles
programmable,
y
as I will
programables,
explain
como
now.
yo les voy a explicar ahora.
So
¿Y
how does
cómo
this work?
funciona esto? Bueno,
Well,
se
the
estimulan las
sacral
raíces
roots are
sacras. Ustedes colocan
stimulated.
un
You
electrodo
place an
alrededor de la
electrode
raíz
around
sacra, ¿no
the
es cierto? Y se
sacral
estimulan,
root and you will
obviamente
stimulate it. Through electricity, you will stimulate the nerve. There's nothing special about this. The issue is that when you stimulate a sacral root, You
componentes
have
parasimpáticos,
parasympathetic
que son los que van a contraer la
components, which will
vejiga,
contract the
pero
bladder,
también
but
hay
you also
componentes
have
somáticos
somatic
que
components,
van a
which will
contraer el
contract the
esfínter.
sphincter.
Entonces no vamos a
So
sacar
you
nada
will
mucho
not
con
get
que se
much by
contraiga la
contracting the
vejiga y
bladder and
se
also
contrae el
contracting the
esfínter.
sphincter.
Entonces, ¿dónde
So
está el
what's
truco
the
aquí?
trick here? The
Bueno, el
trick is
truco es
actually
muy
pretty
ingenioso,
clever.
porque la
Contraction
contracción
of the
de
bladder
la vejiga, ¿no es cierto?, mediada por el
done by the
parasimpático, es una
parasympathetic
contracción que
increases
aumenta
slowly, but it is a
lentamente,
smooth
pero
muscle
es un
that
músculo liso,
slowly
se relaja
relaxes as
lentamente
well.
también.
However, the
En
somatic
cambio,
muscle,
el músculo
the
somático, el
skeletal
músculo
muscle,
esquelético,
contracts
se contrae de manera
instantaneously, but also
instantánea, pero
relaxes
también se relaja de manera
instantaneously.
instantánea. Entonces,
So
se
a
utiliza un
program
programa
is used
que
that
efectúa
provides an
una estimulación
intermittent
intermitente de la
stimulation
raíz.
of the root,
Y al
and
efectuar
by
esa
giving
estimulación
this
intermitente, como
intermittent
se ve
stimulation
aquí,
of the root,
se obtiene
you see
que
that the
se
bladder
contrae la
contracts, the
vejiga
sphincter also
y también se
contracts,
contrae el esfínter,
but
pero
in
en
that
eso la
period you
estimulación
stop
se suspende.
stimulation. When you
Al
stop stimulation,
suspenderse
the
la
external
estimulación,
sphincter
el
relaxes, but
esfínter
the bladder
externo
is
se
still
relaja,
contracted.
pero la vejiga todavía
So
está
in
contraída,
that moment is
entonces
when the
ahí el
patient
paciente
urinates. So the
orina.
patient is
Entonces el
urinating
paciente va orinando de
intermittently.
manera intermitente.
You generate a
¿Ya? Produce el
stimulation, you
estímulo,
contract the
se
bladder and the
contrae la
sphincter, you
vejiga y el
stop the
esfínter,
stimulation, the
y se
sphincter
suspende el
relaxes,
estímulo, el
but the
esfínter se
bladder is still
relaja, pero la
contracted,
vejiga todavía está
and this is how
contraída
you
y
have
ahí se produce
micturition.
micción. Y esta es una
This is
micción
very efficacious micturition.
extraordinariamente eficaz. Esa es
This is how the system works.
La
The
técnica incluye
technique
una
includes a
laminectomía sacra, porque ahí están
sacrolaminectomy.
las
This is where you
raíces, en el
have
canal
the
sacro.
roots, the
Hay que
sacral
hacer una
channel. You have to
raízotomía
do
de
a
las raíces
rhizotomy of the
posteriores, de las raíces
posterior
sensitivas.
roots,
Se
the sensitive
utiliza
roots.
una
You
colocación
place
de
it,
esfínteres de electrodos de
you
S2
place
a
the electrodes
S4.
between the
Ustedes
S2
saben
and
que
the
las raíces tienen
S4,
dos
and you have two
componentes,
components here, the
componente
dorsal
dorsal, que
component,
es
which is
sensivo
sensitive
o
or
posterior,
posterior,
y
and the
componente
ventral
ventral
or
o
anterior
anterior, que es
component, which is
motor.
motor.
Si ustedes
If you
estimulan la
stimulate
raíz
the root
normal,
normally,
intacta, van a producir
intact, you
un
will
estímulo
generate an efferent
eferente, pero
stimulation,
como
but
también tiene,
because you
¿no es
also
cierto?,
have
fibras
some sensitive
sensitivas,
fibers
van a
there,
causar
you
un
will cause
estímulo
an
aferente,
afferent
que es
stimulation, which is
indeseable, porque puede
unwanted,
producir
because you
disreflexia
can have
autonomica,
autonomic
una serie de otros
dysreflexia and
efectos
another series
colaterales.
of
Entonces, lo que
collateral
se hace
effects.
es
So
abrir
you
la
open the
raíz,
root,
separar
separate the
las
fibers,
fibras
the posterior one
posteriores de
from the
las
anterior
anteriores
ones, and do a
y hacer
rhizotomy.
una
So
rizotomía, o sea,
meaning
cortar la
cutting
porción
the
posterior
dorsal side,
o dorsal,
the ones that are
que eso es
sensitive. So you
sensitivo.
do a
Entonces se produce
deafferentation.
deaferentación. Y ustedes
You
ponen
put
el
the electrode
electrodo
on
solo en la raíz
only on the
ventral, o sea,
root,
la raíz
the
motora,
ventral root,
para
so
un
the
estímulo
motor root, so
eferente hacia las
efferent
vísceras
to
que queremos
the
actuar.
intestines that we want to
Entonces,
impact.
hacemos estimulación de las raíces anteriores
So we do a
que
neurostimulation
van a
of the
afectar
anterior roots that will
fundamentalmente
affect
la
the bladder
vejiga,
in order to
van a vaciar
empty
la
the
vejiga,
bladder.
que
This
es
is
el
the objective
objetivo
of
de
the
la cirugía,
surgery.
pero también
But
puede
it can also
ayudar
help
a la
to
contracción del recto
contract the
para la
rectum
evacuación
for
intestinal
bowel
y
movements,
también
and
puede
it can
producir
also
una
produce an
erección
erection
ya
generated
mediada
by
por
this
esta
electrostimulation.
electroestimulación.
How are the
¿Y cómo
electrodes
se distribuyen los
placed?
electrodos? Este es un
This is
esquema que
a
ustedes ven las raíces.
diagram. This is
Este
the
es el
terminal
filo
filum.
interluminal. Las
The
raíces
S5
S5
roots
probablemente no
have
tienen
less of an
mayor rol,
important
pero las que
role.
tienen rol
The
son
ones that
S2,
have the
S3 y
role
S4.
is S2, S3, and S4.
Las raíces
S2 are the
S2
important
son las
ones for
raíces importantes
erections.
para la erección.
S3 and
Las raíces
S4,
S3 y
we know
S4 ya
well
sabemos que
that
son las
they
que llevan
have the
fundamentalmente la fibra
parasympathetic fibers
parasimpática
that control
y
the
controlan
bladder.
la vejiga.
So like I
Entonces,
showed
como
before,
les
the
mostré yo,
receptor
el
block
bloque
has three
receptor tiene
coils,
tres bobinas,
A, B, and
A,
C
B y
coil.
C. Las bobinas A
Coil A
van
are connected
conectadas a un
to the
electrodo
electrode that will
que
be
va a
surrounded and
rodear
will
y
include
va a
the two
incluir
roots
las dos
S3,
raíces
S4
S3 y S4 del
of the
lado
right
derecho.
side.
La
Coil
raíz,
B
la bobina
will
B
include
va a
an
incluir
electrode
un electrodo que
surrounding
rodea
both roots
ambas raíces
S3 and
S3
S4
y
on the
S4
left side.
izquierdas. Y,
And the C
la
coil
bobina C
will include
va a
a
incluir un
double
electrodo
electrode
doble que
that
va
will
a comprometer
simultaneously
simultáneamente
cover
ambas
both
raíces
roots of
S2.
the S2. That is
Mediante la
how
estimulación
through
de
the
la
C
bobina
coil
C
you
se estimulan
stimulate
al mismo
both
tiempo las dos
S2
raíces S2.
roots.
Entonces, con esta
With the
distribución,
stimulation, you
ustedes
can
pueden
do
hacer la
a selective
programación
programming
selectiva
and you can
y pueden
stimulate whatever
estimular
you
lo que
want.
ustedes quieran.
Sorry.
Perdón. La
Dissection
disección se
is done
efectúa a la
in the
salida del saco
termination
dural,
of the
que es
dural
antes de entrar
sac.
al
You open the
sacro,
sac.
encuentra las raíces
You have to
y hay
do
que hacer una
an
estimulación
intraoperative
intraoperatoria para
stimulation
estar
to check
seguro que
and
estamos
see
en
if
la
they
raíz
are
correcta.
connected correctly.
S2 produce
S2
flexión
generates
plantar,
a plantar flexion,
S3 una
S3
contracción
an
anal
anal
que
contraction
también de la
as well
vejiga
as
y
a
S4
contraction for
también
the
una
bladder,
contracción de la
and
vejiga.
with S4
Entonces,
a
para hacer
contraction of the
esto,
bladder as
en la
well.
cirugía vamos
So
a
in order to do this during the surgery, we will monitor intravesical pressure just to make sure that we are impacting the bladder, and also blood pressure, because as you impact it, you can have autonomic dysreflexia. This is the position of the patient's ventral decubitus, with these pillows that allow the abdomen to drop, and it releases the pressure on the veins in the sacral area. Hemostasia is an issue here. Sometimes they bleed because there are a lot of venous plexus, and this separates it, so we can see the anus and see anal contractions. We use magnifying glasses so we can see well, and the patient has their feet exposed so we can see what the plantar reaction is during the surgery. They have a Foley catheter connected to a urination measurement instrument. We do a mapping of the stimulation of the roots intraoperatively to see what electrodes and what roots are actually working, because this is not symmetrical. Sometimes a patient can have better stimulation with the right roots on the right than the ones on the left, so we do a mapping. So let me go back. You can see here how we are stimulating it during the surgery with an electrode, each one of the roots, and the engineer who advises us, she checks this mapping, logs this mapping that will later allow us to do a programming of the system. So what are the results? These are the results published by these European groups. Sorry. Interestingly enough, this is all from the 90s, but it has been proven that it is very efficacious. You get urinary continence by 80 to 90%, as you can see with all these theories, with an important number of patients. You get an increase in bladder capacity with all patients. You get the possibility of complete micturition with a residue lower than 50 cc in 70 to 90% of the cases, so meaning the effectiveness of the system in the urinary system is actually very high. It has also been proven with these publications that the SARS system has shown to increase the quality of life of patients with a decrease in urinary tract infections. It allows independence as well as continence, and this impacts the quality of life. In summary, this technique is reliable, you can replicate it, and highly efficient. It controls micturition, emptying the bladder completely at will, and you get continence in 80 to 90% of the cases. It also helps with the intestinal side of it. 70 to 90% of the cases have indicated this. It may trigger erections, which may be helpful with some patients, but let us remember that rhizotomy gets rid of reflex erections, so you should review this with the patient. And it brings down urinary infections, and the most important thing is that this patient can stop catheterizations. They do not need to use intermittent catheterizations. It increases bladder capacity. It decreases autonomic dysreflexia. It disappears the afferents, therefore autonomic dysreflexia. And it has a reasonable morbidity below 10%. What are the requirements? This is for patients with complete suprasacral injuries. It is not recommended for incomplete injuries because it produces pain, and the patient has to have been stable for at least a year after their spinal injury. Only hyperactive bladders. This will not work with hypoactive bladders because of the subsacral or sacral rehabilitation process must have been stable. They have to be free of sores, no comorbidities, and they have to have a basic level of understanding of how to use the device. We started our experience with this in January 2013. So far, we've operated on 16 patients, most of them males, most of them post-trauma, 8 tetraplegic, 8 paraplegic. Time of injury before SARS, 44 months. So we wait for the patient to really understand, to be adapted to their situation. Refractory hyperactive bladder with conservative management with anticholinergics and botulinic toxins, and follow-up for more than 50 months. Here's where I show the pre-SARS and post-SARS situation regarding bladder function, defecation, and erectile function. So from the bladder point of view, they all had hyperactive bladders with intermittent catheterization, and most of them with oxybutynin. Some patients had experienced trauma to the urethra because of the catheterization. urinary tract infections that were recurrent. One patient had low accommodation. After implanting SARS, all patients had the capability of using the device, and they would urinate 4 to 5 times a day. They were continent and very good volumes with little residue. One patient had stress incontinence because of the rhizotomy, probably, that weakens the somatic part, but it was corrected with a male sling, and this patient was able to continue to use the SARS very well. 2 patients had failure because even though that we did a rhizotomy, they weren't able to increase the bladder capacity. So with these patients, we had to do a diversion. Regarding constipation, which is often in these patients, all patients using the device, and it helps them to have a bowel movement. Regarding erections, we have 13 patients that are males, and out of these 13, 6 of them were sexually active with reflex erections. These patients who were previously active, while SARS can produce an erection in most of the cases, in 11 of these 13 patients, only 6 of these people were able to continue to have a sex life using SARS. While it is true that the SARS helps you with an erection, it is not necessarily a useful erection for sexual activity, so therefore some patients had to get a penile prosthesis. These are some of the far and between issues that we've seen and we would like to convey to you. First of all, it is very important to get trained. We've had some issues with tetraplegic patients who need caretakers. If the caretaker is not well trained, they can cause damage to the system, and they change caretakers. So caretakers are in charge, and these caretakers are not often well trained, and this can generate some important issues. External components may fail, just like any mechanical device. Internal component failure, yes, we've had 2 patients that had an extrusion of the antenna because of the incision. We've had to re-implant the antenna. 2 patients had failure, like I said, the urinary part. We had to do a diversion, and 4 patients had to get a penile prosthesis because the erection was insufficient. However, in summary, SARS, in our experience, has resolved the urinary problem for 88% of the patients. We have resolved the intestinal problem by more than 94%, and it allows sexual activity in a third of the patients. That is why we believe that the best candidate for SARS is a paraplegic woman or paraplegic male who is not interested in a reflex erection. And that is why selecting the patient is key. This is a limitation for the use of the system because it does require a pretty broad multidisciplinary team in order to select the patient, which will include our rehabilitation team, physiatrists, psychologists, physical therapists, nurses, and occupational health specialists, etc., that help us to select the best patient. And from the surgical point of view, you need a neurosurgeon, traumatologist. We have to work a lot with the anesthesiologist because the intraoperative anesthesia is important, and this effort does require significant coordination that is not always available. However, the results are amazing, and well-selected patients, well, this represents an alternative for treatment that we believe should be more broadly used. So I thank you very much for giving me the chance to review this option with you, hoping that this means that there is a possibility to incorporate it more broadly for our patients here in Latin America. Well, I will wrap up with this, and I would like to thank you once again for the opportunity of being with you and to present this talk. Thank you very much.